Hello everyone, my name is Jen Nolan and I'd like to welcome you to our webinar this evening. We are very grateful to Peninsula Hot Springs for sponsoring this webinar. Peninsula Hot Springs is an award-winning natural hot springs and day spa destination on the Mornington Peninsula, just 90 minutes from Melbourne. We will also be having a stretch break during the webinar, compliments of Peninsula Hot Springs. In line with Musculoskeletal's Australia's focus on empowering consumers through education and support services, we have been offering a series of webinars for a consumer audience during 2019. Our list of webinars should be on your screens now. Now, I know some of you may be watching a webinar for the first time, so if you have any problems during the webinar, please phone the number at the bottom of your screen. As a backup, everyone will receive a recording of the webinar presentation next week, so if any problem can't be resolved this evening, you'll be able to view the recording. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, if you are listening via the phone, you may not be able to hear the audio during the exercise break video, but it will be available on the webinar recording when you receive it. Our presenter for this evening will answer questions at the end of his presentation, but you can type questions for him at any time. The Ask a Question button is the dark blue hand icon in the top right corner of your screen. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Summer Time. Questions will only be answered during the webinar, so again, this is a reason to not leave your questions to the last minute. I would also be very grateful if all participants could provide feedback on tonight's webinar. To submit feedback, click the yellow icon in the top right-hand corner of your screen. Our presenter for this evening will be Dr. Adam Castricum. Adam became a fellow with the Australasian College of Sports Physicians in 2008. He was appointed Chief Medical Officer for Athletics Australia soon after and headed up the medical team for the successful track and field team at the 2012 London Olympic Games. In 2015, he joined the Australasian College of Sports Physicians Board as Vice President and was President of the newly named Australasian College of Sport and Exercise Physicians between 2016 and 2018. Adam is passionate about sport and exercise and takes great satisfaction out of helping all members of the community achieve their goals in a safe and healthy fashion, whether they are elite athletes or simply inactive patients wishing to get active and lead a healthier, more rewarding life. We're extremely grateful to Adam for presenting this evening's webinar, and without further ado, I'll hand proceedings over to him. Thanks very much, Adam.
Thank you, Genevieve, and thank you also to Peninsula Hot Springs and Musculoskeletal Australia for the opportunity to be able to speak to you all tonight. I'm hoping that I can give you a nice little, presentation around practical ways that you can keep your knee healthy in the setting of chronic disease. And I say keeping your knee healthy is because I think, we're talking about knee osteoarthritis, but I want to think about this in a way as how we can empower you all to be able to your knee and have a very healthy life. Not that osteoarthritis is going to lead to they have a worse life. So I want you to really sort of think about it. This is how we're going to make your life a lot better, but with managing osteoarthritis. So the first thing is my personal disclosures. I don't have any. Look, I work at Olympic Park Sports Medicine, which is in Melbourne, and is at Amy Park in the city. And I've been on the president of our college for the last 3 years and still remain on the board. And I'm very passionate about improving patient outcomes in terms of pain, function and quality of life. And so I guess this is where I'm quite passionate about the way that we manage osteoarthritis in the community. You might recall sort of early last year, there was an insight program on SBS where they were sort of talking about how people were getting lots of surgery on their knees and not really getting any better, and how there was a real disconnect, I guess, between the current way that osteoarthritis is managed in the community and what the current evidence is actually saying now, in that surgery is not really what we need to be doing for osteoarthritis, but it's more around exercise, weight loss and strengthening. So that's what we're sort of going to go tonight, because there's been a real, confusion about how this is managed currently. And there's a lot of other conditions, that have also changed away from like low back pain and knee pain, that we've got to start working out how to do this better. And I guess back last year, or at the end of last year, there was a national osteoarthritis strategy that was launched. And you can see the numbers there just around how common osteoarthritis is. It's the most common chronic joint disease in Australia. with 1 in 5 Australians reporting very high distress with having it. 2 in 3 people have osteoarthritis, a female, and 1 in 8 Australians are affected by osteoarthritis. And we're seeing this dramatic rise in knee replacements, which I'll talk about soon. And basically, more than 1 in 2 Australians with osteoarthritis report moderate to very severe pain. And I guess we have to be better at how we manage these. If we look at osteoarthritis as we get older, the prevalence of osteoarthritis increases. And what we find is that, as I said, it's more prevalent in females. And certainly over the age of sort of 50, we're seeing this now. And also now we're seeing it even younger. But also in people who have osteoarthritis, there is a high prevalence of other chronic conditions compared to those without osteoarthritis. So if you've got osteoarthritis, you're more likely to have a chronic condition. And I guess I'll talk about those soon, but it's actually more prevalent also, osteoarthritis, in the Indigenous population. Now, chronic diseases, 50% of Australians actually have a major chronic disease. And 25% of them have 2 or more. So this tends to be higher in lower socioeconomic areas, regional, remote and Indigenous communities. And when I talk about chronic diseases, obesity is one of those. And now it's about 30% of Australian adults actually have obesity. Others include cardiovascular disease, diabetes, cancer, asthma, dementia, and mental illness. So when we say that people have one, they may just have osteoarthritis, but the other one may on top of that be cardiovascular disease, diabetes or obesity. And obesity is really the one that can get us into trouble. As far as knee arthroscopies, back in 2014, 2015, there's about 80,000 of these being performed, which is way too much given that the evidence for these has actually not been around for at least a good 15 years, but even more so in the last, I guess, 7 years. There was a study done back in 2013 in Scandinavia, which basically looked at people having knee arthroscopies because for a waiting list to have a knee arthroscopy. And what they did with the group is they randomised them into a group where they would both go into hospital, have a general anaesthetic and be put on the operating table to have surgery, with only one half getting the arthroscopy and the other half just getting an incision in their knee. But what they found after 2 years, that the outcomes, depending on which way you went, were exactly the same. And we've known for many years also that if you do an exercise program as opposed to have an arthroscopy, the results also are exactly the same. So there's actually no evidence that having an arthroscopy for knee osteoarthritis improves outcomes. And what is also happening, and so it's been recommended in major international medical journals, that we should not be doing knee arthroscopy for osteoarthritis. And in fact, we should only be doing it if you have a locked knee, so a locked meniscus or a loose body sitting inside your knee, which I'll talk about soon. One of the other things that is a bit of a concern is that the number of knee replacements in Australia is going right up. There were 46,000 performed in 2014, 2015, and it's an average cost of $19,500 for that. And it's gone up 285%, so 3 times it's gone up in the last 20 years. And this is also a concern because this has increased hospital costs. And what we're also finding is that it's actually happening younger and younger. Now, this is a study that came out just recently, and this is really concerning. This is looking at about 850,000 people who've had a arthroscopy for their knee in the last 20 years. And what it basically says is that if you have an arthroscopy to take out some of your meniscus, which is part of the arthritis process, you are 10 times more likely to have a total knee replacement in your lifetime. And if you have it really young, so that is between the age of 30 to 39, you're up to 40 times more likely to have a knee replacement. So I guess the message here is that if you're going to have an arthroscopy, you really want to have a good reason for why you're going to have it. And it's not just because you've got knee pain. So, and the other thing is that if you have an arthroscopy on one knee, then it's 3 times more likely to have a knee replacement than the other knee that may not be actually sore. So I guess what we're looking at here is that knee replacements are going up, and in younger people, so the green line on this, we're seeing that it's pretty constant, but in the sort of the yellow line, it's starting to go up when people are having their total knee replacements, which is reasonably normal. But what we're seeing is if you have them younger, you're more likely on this one, the green one, to have a total knee replacement, a revision, because the metalwork tends to last sort of 15 to 20, 25 years. And I will say to all my patients, it's up to I need to help you get be as active as you can all the way up to 100. That's important. So we don't want to be having people having surgery early. And what we're finding in Australia is that luckily with this evidence, the number of arthroscopies, which is the red line on this graph, is starting to come down. And this is from 2013, which is good. And the total knee replacement levels are now starting to level out. And I think that's because there's probably better guidelines around how to manage osteoarthritis. But I think also we're seeing that people are having MRI. Back in 2012, the government allowed GPs to do MRIs of knees, which blew out the budget by a couple of $200 million. But you'll find later that we don't need to be doing MRIs of the knees because they actually don't give us the appropriate information, and they may lead to surgery when it's unnecessary. So the importance of looking after osteoarthritis is, I guess, it's not with the surgeons completely. It needs to be a team thing. And back in 2017, the Australian government launched a clinical care standard for the management of osteoarthritis. Basically, I'm going to take you through this, what it says in it. It was further revised in 2018 with the College of GPs, who then looked at the management of knee and hip osteoarthritis and looked at the evidence to make sure that GPs, allied health professionals, and all doctors were actually managing this in the correct way. And when they did this, they actually then launched guidelines, which you can see in this slide, which talked about, I guess, interventions that had the green light, so there was evidence for them to be done, so there was a strong recommendation for them to be done. There are others that were conditional recommendations for. And then down the bottom, as you can see, the surgical management for knee osteoarthritis, it showed that we should be only referring for an arthroscopy unless you have a mechanical locking of the knee. But the other thing, it was also only considered joint replacement surgery for severe disease when all of the conservative options, all the green things up higher, have really failed. So I'm going to take you through a lot of the green things tonight and tell you how we can best manage this so that hopefully many of you won't need to see an orthopaedic surgeon for surgery for your knee. And I guess there was a lot of work done through Move Australia with Musculoskeletal when they looked at the Victorian model of care and how we can do this. This is back in 2018. And I guess we look at the continuum of osteoarthritis, and it's important that we manage this very early on in the disease, not just at the end stage when I guess you can't walk and you've got too much pain. And I guess we look at there's three ways that we can do this, and everyone should be getting the non-pharmacological, non-surgical care, which includes education and reassurance, pain management, exercise, and weight control. Everyone should get this. Some people should get some medications or injections, and then only a few should get surgical care down the track. So we shouldn't be having it in those tens of thousands that we were seeing in those graphs early on. And I guess they look at a holistic model of management that it should be, there's many layers to this, and it should include, that's a very sort of busy graph there, but I guess we're looking at a model of care that we look at reducing the amount of wasteful, I guess, imaging and also interventions. And osteoarthritis itself can actually be diagnosed clinically more by having knee pain that happens with activity. You can get an x-ray if you need to, and that should be the first-line imaging choice and not MRI scans, unless there's an atypical presentation. So you've got a pain that's actually really not settling despite doing a lot of the non-surgical management options. It's interesting, in 2018, the government is reviewing a lot of the funding for a lot of these interventions, and they actually stopped GPs ordering MRIs of knees in over 50-year-old patients from the 1st of November. Some of those MRI numbers have actually now really dropped, which I guess is now freeing up money that we hope to see goes driven back into how we can actually manage osteoarthritis in a non-surgical manner. So hopefully funding it back into physiotherapists, exercise physiologists, and psychologists, and also better access, I guess, to sport and exercise physicians in regional areas where there's a higher incidence of osteoarthritis. And there's also a study that came out last year that basically said that you can have no knee symptoms, but if you have an MRI of your knee and you're over 40 years old, up to 43% of those people will actually have osteoarthritic changes, although they don't have any pain for osteoarthritis. So it's actually not worth doing the MRI over the age of 40 even, because it doesn't really differentiate between those who do have those who do have pain and those who do not. It's all going to, and there are a lot of people out there can actually function with the changes of osteoarthritis in their knee without pain. So that actually lets us know that you can actually function very well with those changes in your knee if you do all the non-surgical things. So I guess looking at an X-ray, this is what we look at. We're looking at the X-ray so your left-hand side is the right side, because when they're doctors, we look at you from face on. It's got a couple of screws inside this right knee, which shows that someone's previously had a reconstruction of their anterior cruciate ligament, which means they probably injured their knee when they were younger and had a reconstruction because they had an unstable knee. That operation alone, or that injury alone, does increase your risk of osteoarthritis. And in this, we can start to see narrowing of the joint spaces in the outside part of the knee, so what we call the lateral aspect of the knee, where the arrows are, which would suggest that you'd have pain on the outside of your knee. Now, that is enough to give us an idea that you do have some osteoarthritis. When we go to the next slide, this is what an MRI will look like when we often see this, and it's very common to see this finding. So this is, you can see the top part is the thigh bone, the femur, and the bottom part is the tibia, which is the shin bone. And in the middle there, this black line where there's an arrow is the meniscus, and this shows a meniscal tear. But as we know, we don't need to have an operation on your meniscus to fix your knee, but this is very common that a lot of people have this but do not have pain in the knee, and they actually function very well with this, and they can also have loss of cartilage. So I guess the problem is that if you get an MRI scan, you'll get a report, and a report will often say this. This is a complex medial meniscal tear, full thickness cartilage damage with some inflammation or bone bruising underneath the bone in the weight-bearing portion of the medial femoral condyle, which is basically saying you've got some osteoarthritis in your knee. But a lot of people will look at this and go, ouch, I've got a meniscal tear, so that needs to be fixed. I've got a full thickness articular cartilage defect, that needs to be fixed. But the reality of it is these structures in the knee do not have a blood supply, so they can't heal. But they serve an important purpose inside the knee to actually, the meniscus helps to cushion the knee and stabilize the knee and give it some stability. So it's important that we keep it in there, otherwise the knee can become a little bit more unstable. But if we strengthen all the muscles around it, it keeps the knee stable. So I guess that's why we don't want people to have MRI scans, because if you get this sort of report, that report can start to own you and mean that I've got to get my knee fixed and all this has got to be fixed for me to be right, but that's not true. It's important that the patient really owns the scan, and that's why I say to people with an assessment, it's most important that we treat the patient and not the scan. And people can be paying $320 for an MRI scan if they're not getting it through a specialist, or if they're over the age of 50 now, so if they get it through a physiotherapist or an osteopath, there's $320 they're paying out of pocket that I think should not be used for that, but should be used for physiotherapy, strengthening exercises, or to do some more exercise. So it's important that when we're treating osteoarthritis, it's got to be holistic and it's got to involve the patient. It must consider the biopsychosocial model. We've got to look at the social factors and social supports that the patient has in their beliefs, and the concerns and any barriers that they have about why can't they move with their osteoarthritis and what does their pain mean to them, how it might affect their occupation and how it might affect their sleep and their mood. Because at the end of the day, if you can't sleep, you're grumpy, and if you're grumpy, then your function's not great. So it's important that we allow people to get to sleep well. So we've got to consider their attitudes to exercise and any other chronic diseases that they may have. And what we'd like to be seeing is that patients start to tell us exactly how they feel with pain and function scores, and that's what we talk about here with the PROMs, which we're hoping to see a lot more now that we've got, I guess, digital technology, which might be on a phone that you can put in a survey just to say how you're feeling. And there's a knee injury and OA outcome score that we look at. So this is what we're looking at moving towards when you see your doctor or your physiotherapist, that they'll want to know how do you feel, and they'll score you and just see if you're starting to improve. And so the model of care for osteoarthritis now needs to be a multidisciplinary team of health professionals, not just an orthopaedic surgeon, where treatment plans are shared and coordinated between health providers, with the GP acting as the central care coordinator. The GP must be, everyone must have a GP who coordinates all their care, not just for other diseases, but particularly for osteoarthritis. And we need to manage the whole person. So osteoarthritis is not just a knee issue, it is a whole person issue. So obesity certainly contributes to this. It can cause inflammation in that knee as well. So there's a whole person that we need to manage, and we must pay attention to managing all those other comorbidities, so hypertension, diabetes, asthma, mental health issues as well. One of the great things about exercise is that it's very good at managing mental health issues like depression and anxiety, because the more you move, the better you feel. And I guess this is where it's important. Rest and doing nothing is bad. It's bad for the joint, it's bad for your mental health, so it's important that we get people moving. And the other thing is we would like to be able to shift the care of osteoarthritis away from hospitals and move them into local community settings. So whether it's community-based centres near GPs, or say a centre like we've got in Melbourne, Olympic Park Sports Medicine, which is a multidisciplinary centre where we've got sport and exercise physicians, registrars, physiotherapists, exercise physiologists, we've got psychologists, we've got dietitians, we've got a whole group of people who can actually help to manage osteoarthritis. And the other thing is whether we put these into outreach services for rural and regional areas that, again, so I guess the GPs would also be having physiotherapists and dietitians and having exercise physiologists also working in their clinics, which is the way that we must be moving with this. So I guess, as I say before, there's lifestyle, pharmacological issues and surgery, and these are all these things on the right. And I'm going to talk through those after this little break. So I want you to just have a little bit of a stretch and enjoy. These are the things, I guess, who deliver these things. Before I go to that, is the lifestyle is your allied health, and all medical practitioners need to be able to do that. The pharmacological domain is really the domain of the doctors, and then the surgery is the domain of the surgeons. And I put in bariatric surgery there for the really obese people, although we prefer people not to get to there with their obesity, and they can lose their weight through lifestyle interventions up at the top. So as I said, I'd like you to enjoy this little exercise break, have a stretch, maybe walk around for a few minutes, and I'll be back after this, and then we'll go through all these ways that I can help you to manage your osteoarthritis and make your knee as healthy as it can. So thank you.
And today I'm going to take you through my stretch and release program that I've designed for the Peninsula Hot Springs. We're going to be working the entire body, focusing on both static and dynamic stretches, which are beneficial for both body and for mind. We're going to be working on the performance of your entire body whilst improving flexibility and range of motion, whilst also aiding in relaxation and stress. All you will need for this workout is a yoga mat and a positive attitude. Let's get started. Throughout this entire sequence, we want to keep a huge focus on the breath. The breath is so important when you're stretching. You want to inhale through your nose, exhale through your mouth, reoxygenating the blood. Taking your hands lightly onto your rib cage. Inhale that nice lateral breath out to the side. Exhale as you pull the rib cage back down to your center. Inhale out and exhale down as you come back to your center. That's the breath pattern we want to work on throughout all the moves. We're going to start standing nice and tall, feeling your feet grounded into the mat. Imagine you have two lines running straight up through the middle of your body, past your kneecaps, past your hips, up past your chest and out through your shoulders, standing tall with your shoulders pulled slightly back behind you. I want you to drop your chin to chest, and we're going to roll down into a nice spine curl, vertebrae by vertebrae as you roll all the way down, and letting your head relax at the bottom of the movement. Pulling your belly button back to center as you scoop all the way back up to standing, and just let your shoulder blades go behind you. And again, chin to chest, rolling down, vertebrae by vertebrae, really feeling it unpeel. Then I want you to nod your head yes and no. No and yes. Yes and no. No and yes. Scooping your chin to chest, belly button into your centre and curling all the way back up and roll your shoulder blades back. Then we're going to get the body moving, nice dynamic movements. Inhale as you sit back through your heels. Exhale as you pull forward. Just small little squats on the spot. Exhale as you pull forward, focusing on that stomach and that belly button pulling into your centre. Exhale as you come through. Once you feel yourself starting to warm up, we're going to add a calf raise. Come up onto your toes, down through your heels, back into the squat, all the way up. Getting everything moving, waking up the back chain of your body. Inhale down, exhale up. 10 to 15 of these.
Thank you, and thank you again to Peninsula Hot Springs for that video. So first of all, as I said, I'd like to start off with lifestyle interventions, and I guess the first one is education. And I guess I have my consultations are generally, my first one is about 40 minutes, and my subsequent ones can be 20 to 30 minutes, and sometimes longer, because I spend a lot of time about talking about the education about osteoarthritis, and I guess what we've spoken about before, and how osteoarthritis works, but how it's best managed. And to explain that condition, what is normal, I guess, for people's age, their previous activity history, and I try and set expectations that we can't particularly fix the knee, because people they want the knee fixed, they want a magic bullet, but often we can't do that. And it's more about self-management. It's more about empowering the patient to, as I said, this is your healthy knee. It's not just because the MRI says that it's got all these things wrong with it, doesn't mean that it's necessarily unhealthy. It's part of the aging process, but it's also that, as I said, there's a lot of people can have abnormalities on the MRI scan, but they don't have pain. So they've actually been able to manage their knee a bit better through, I guess, strengthening and load management and often weight loss. So the other thing I'm very cognizant of is I always say to my patient, if I've got $500 of your money to spend, and often people have come in and seen me and spent thousands, and they don't want to spend more. And I've got to be really careful about how I spend that next $250, $500, and hopefully some of it gets a rebate as well from Medicare, so that they can get the best value or the best bang for their buck for that care. And I guess there's this new paper that's just come out. We need to start changing the way that we talk about knee osteoarthritis by, I guess, changing the message. And this slide's here quite good if you get to have a chance. And it's got on the left-hand side myths and, I guess, what is low-value care, so things that don't really help. And then on the green is, I guess, the facts around osteoarthritis, and on the green is what is high-value care. So what is going to be the best bang for your buck? And they're the things that I'm going to talk about here today. So it's important that the patient is in charge of how they manage themselves, because a lot of the way that we do it is more active interventions, as in the patient needs to do something, as opposed to a passive intervention, which is more just turning up and getting some treatment and then walking away going, well, that didn't really, it may have helped or it maybe didn't help. So I'll tell you the ones which are those that do help. As far as smoking goes, look, we all know that smoking it increases your risk of a lot of chronic diseases, and it's not good for osteoarthritis, and that you'd have greater cartilage loss and certainly can have more pain. So again, no smoking. I think we all agree with that we shouldn't be smoking. The biggest one is weight loss. There's a great paper that actually said if you reduce your weight by 10%, you can reduce your pain scores by anywhere between 30 and up to 50% in pain. Now, the best anti-inflammatory on the market, whether it's Voltaren or Naproxen or Celebrex, gives you about 25% pain relief. So my message always to those who are obese, so the BMI over 30 is to try and lose about 10% of their body weight, which can be done over about 6 to 12 months generally. I like to tell people to try and lose a kilogram per month, because that's healthy and it's also sustainable. Certainly crash diets I don't like. The best ones are probably trying to low carbohydrate diets, or looking at sort of the fasting type diets, but it's really difficult because there's so much information out there, and also the nutrition guidelines are always changing with new evidence. Weight loss will help improve physical function, also reduce the chronic disease risk, particularly things like diabetes and high blood pressure. And we also know there's in lots of studies that look at, if you're going to pick one thing, what would it be, fitness or being overweight or obese? Fitness is the most important thing that you can do. So being physically active, regardless of your weight, is so important. And you can't always outrun a bad diet. As much as you can try, I'm going to lose weight through exercise, it doesn't always happen that way. And it always needs to be a combination, I guess, of exercise and what I call nutritional modification, because the reality is 95% of diets don't work, and we need to actually look at our longer-term eating habits. And I guess recently there's been a lot of positions put out there. There's been the CSIRO, low-carb diet. There's a Fat Lot of Good, which is the low-carb, high-fat diet from Dr. Peter Brookman, who's a sport and exercise physician. There's Dr. Michael Mosley, who's a GP in the UK, talks about the fast diet. The College of Physicians in Australia put out a physician statement on obesity. And then there's the Australian Guide to Healthy Eating, which is the current, again, this has just been changed again, but it will continue to be changed as there is more evidence that comes out. So this is very much a watch this space, but it's also important to consult your GP or your sport and exercise physician or your dietitian, who can give you the advice around weight loss. It's important this becomes as I say, a habit and a lifestyle thing, not just trying a crash diet. And what I say to my patients often is, when you go to the supermarket, I want you to just stick to the perimeter of the supermarket. I don't want you going into the middle lanes, because that's where all the processed foods and the processed carbohydrates are, which is not what you shouldn't be eating. You should be sticking just to water and trying to limit as much and alcohol as you can. Certainly not drinking any of the fruit juices, because they're loaded with lots of processed sugar, and that's not what you need. As far as we sort of say, as far as as fitness or exercise, people who are physically inactive, just look at this graph here on the left. If you are physically inactive, you are high risk for dying early than a combination of smoking, diabetes, and obesity. And we call this smoker diabesity. So low fitness is actually your greatest risk factor for early death. And it's important that people exercise. And I love this line here. Those who do not find time for exercise will have to find time for illness, because exercise is actually very, very effective at not only treating a lot of chronic disease, but also preventing chronic disease. And this is a paper that just came out in the middle of this year in the British Medical Journal, which is a very, very highly rated medical journal in the world, saying that physical activity, some of the potential benefits of this, and this is just walking 10 minutes of brisk walking a day, is likely to reduce your chance of dying by up to 15%, irrespective of your baseline fitness. We talk about doing 15 minutes of exercise, of brisk walking a day, will add 3 years to your life. If you do the exercise guidelines, which I'm going to show you next, it adds 7 years to your life. But you can see across all these domains, it lowers 20% lower risk of breast cancer, 20 to 35% lower risk of cardiovascular disease, reduce your incidence of osteoarthritis by anywhere between 22 and 83%, diabetes by 30 to 40%, depression and dementia by 20 to 30%, colon cancer 30%, and a reduction in falls in the elderly. If exercise was a drug, it would be the biggest blockbuster drug on the market, but it's not. This is the thing that we need to get more funding for, is getting people more active and instructing them about getting active, because it will help them on over so many health benefits, not just osteoarthritis. And as I said, a lot of people with osteoarthritis also have many of these chronic diseases. And these are the National Physical Activity Guidelines for 18 to 65s. And it's doing any physical activity is better than doing nothing. And if you currently do nothing, you should start by doing a little and just gradually build up to the recommended amount. And we like you to accumulate anywhere between 2.5 to 5 hours of moderate intensity physical activity, which might be just doing brisk walking for many of you, or it's dancing, or it's doing a bit of swimming, or it's walking upstairs, or it's walking your dog even. And vigorous activity such as running, you can do anywhere between just over an hour to 2.5, so running or team sports, or an equivalent combination of these each week. And you should also be doing strengthening exercises at least 2 days each week. The other important thing is to minimise the amount of sitting that we do. It's not good for us. We need to break up long periods of sitting as often as possible. And in those over 65 years old, you should be doing at least 30 minutes of moderate intensity exercise, such as brisk walking a day, and adding in flexibility and balance exercises as well each week. So things like Tai Chi or clinical Pilates or yoga, you can add those things in. So this is the physical activity guidelines for Australia, which is the same as around the world. And again, there's a moderate strong evidence for health benefit across all these things, particularly in the elderly, falls, frailty and physical function, but also anxiety and depression, sleep, quality of life, your cognitive function, all these other things that I was talking about before. But it's most important in our children, where only 9% of Australian children, teenagers, actually do enough physical activity. And that's 60 minutes a day. So I guess the message here is do anything. It doesn't matter what you do, as long as you do something. And the issues to this is often body image. A lot of people don't like it. They don't like being outside, or they don't like being in gym gear, or they don't like being in pools and swimsuits. 50% of people with osteoarthritis will suffer from depression at any stage. They'll often have anxiety. And as I was saying before, exercise is a very good drug, I guess, for anxiety and depression. Certainly people with cancer, there's the cancer guidelines that exercise have just been released, and exercise is actively encouraged for every cancer patient, whether they've currently have cancer or they've had it in the past. It's good for helping with treatment and also for prevention down the track. Also, but it's important that the GP or a sport and exercise physician discuss this with the oncologist who's in charge of, I guess, the cancer treatment, and also cardiologists if you've got heart disease. But there's not many reasons why you can't do exercise unless you've got a really unstable condition, and the oncologist and cardiologist will know what these are, also with the sport and exercise physician. The other thing often is affordability is an issue of equipment, concessions and private healthcare. This is where there's been a lot of work done at the moment to try and make exercise prescription or exercise treatment a lot more affordable and accessible, not just to people in the major cities who've got private health, but also to under Medicare. Currently, you can access a chronic disease care plan with 5 visits to a physiotherapist, exercise physiologist, dietitian or a podiatrist, or any mix of those 5. You get 5 sessions in a year. And you do need to have that referred to from your GP. So there is a Medicare benefit for that at the moment, but we're actually hoping that we can increase that to way more than that, maybe 10 or 20 in a year, so that people can get better access to this rather than getting an MRI scan or getting surgery. The other thing is time, and as I said, you just need half an hour a day to do this, or even 15 minutes, and also the motivation. And I think being able to live longer, see grandkids and be active and do travel should be enough motivation. Be healthy should be enough to get people doing more things. And I guess the big message I say to my patients, it is actually safe to move. We try and limit the impact. I try to give people do low impact activities such as brisk walking or cycling or stationary bike indoors, water-based activities like hydrotherapy or swimming or water aerobics, or just any way that you're moving and getting your heart rate up a little bit, so that you can actually feel a bit of a sweat, or that you're actually finding it difficult to hold a full sentence. I always say to people, make it social. So with your partner, in a group, or pet, if you're living by yourself, get a pet or go into a walking group. There's a great initiative called Park Run, which happens in most towns now around Australia, where people can do a 5-kilometre walk or run on a Saturday morning at 8 or 9 o'clock in a local park. And it's all volunteers. There's nothing to join. And I think that's an excellent way of actually making your activity more social. And you should be looking at doing this anywhere between 3 to 5 times a week. And we talk about 5 30-minute sessions, but it doesn't matter how you do it. You can do it 15 10-minute sessions, or 10 15-minute sessions, or even 35-minute sessions. It doesn't matter how you do it. They're just as effective as long as the cumulative dose gets above 150 minutes a week. And if you've got severe osteoarthritis, particularly in your knee or moderate arthritis and a bit of pain, I say to people, maybe have a day off or a couple of days off before you go back and do a little bit more of walking to allow yourself to recover, and perhaps do some lower impact activities on the other days. As I said, we're trying and hold a conversation but not sing. And as I said before, 15 minutes brisk walking a day can add 3 years to your life. And there's a great paper put out last year which actually said if you walk just a little bit faster than just a casual stroll, you can actually reduce your risk of dying by all diseases by about 20%. So there's a lot to just be walking a bit faster, walking like you're in a hurry. one of the best ways to actually clock up a lot of activity is actually incidental activity. Now, this might be when you go shopping, you park your car furthest away from the shops or from work. Don't be afraid of stairs or hills. Don't get on travelators. Don't get on escalators. Walk up the stairs like we have in this photo here. Perhaps look at a standing desk so you're sitting less if you're at work. Getting off the bus and tram train early and walk the extra distance if you can, the extra stop, or walking your kids to school, walking lunch. Sometimes even our psychologist here has a walking consultation out in the park with patients, helping the kids with sport. My office is at the end of the hallway, so I actually do a lot more steps than my colleagues who are closer to the waiting room. So I can get up to 7,000 steps a day. And we've got 3 children, obviously a young 4-month-old, and every day you pick them up. That's a progressive resistance program that, so if you can't get to a gym or clinical Pilates, a lot of it is actually by lifting up your children. So these are little tips, I guess, how you can increase your incidental activity. And I've got an Apple Watch, and on this there's a health document or the health app, and you can actually pull up how much exercise you've done in a day, and I've got an Apple Watch as well, so I actually can track it on there. But this just shows that I'm getting sort of 39 to 40 minutes a day of exercise over each year over the last few years, and this year I'm tracking about 39 minutes. So these are the sort of things that I'll look at when patients come and see me. I'll also look at their step counts. But it's interesting when we look at step counts because we talk about 10,000 steps a day. And there was a great study done earlier this year, it came out in May, which basically said that you do not need to do 10,000 steps a day. It tends to plateau out at about 7,500 steps a day. And this is looked at women at a mean age of 72, and they looked at their steps over 7 days. Now, if you only did 4,500 steps a day, which is about what inactive people do a day, they had significantly lower mortality if they got up to 4.5 compared to, say, 2,700 steps a day. But if they got up to 7,500 steps a day, there was no added benefit of doing more than that. So you don't need to go to 10,000 steps a day to actually reduce your mortality rates. It tends to figure out. Now, unfortunately, this slide hasn't actually showed the graph, but I guess what it says is that 10,000 steps is not the magic number. 7,500 steps a day is the magic number, particularly in the elderly over 65. So avoiding injury is always also important because there's nothing worse than going out and doing exercise and then you get injured. It's important that you have comfortable footwear, well-cushioned footwear. We tend to replace these every 6 months or 500 kilometres, particularly for our runners. Ensuring that your clothing is comfortable. As I said, sticking to high-impact activities such as, say, running or, say, tennis or your sport do it on alternate days, not consecutive days. So don't try and do sort of 2 games of 18 holes of golf on a weekend. You will get sore. Monitor your fatigue and pain and wait until that settles. You don't have to wait until you're completely pain-free, but you do have to wait until you get a little, the aches, certainly the sharp sort of pain subsides and a little bit of an ache is okay. There is a role for massage and myotherapy in the GP guidelines. They certainly recommend this to help with releasing tight muscle structures. And certainly with loads, so if you're doing a lot of walking or a lot of running, I try to say to people, don't increase your volume by more than 10% a week. And it's also important that you do a strengthening program with any exercise programs. You must be strong enough to carry the load that you want to put through your body. And so the strength program is here. We focus on resistance exercises for particularly your lower legs, around your glutes and your core and your quads and your calves. Generally, it's twice a week. And this is a program here on the right called the GLAD program. And it's a great study out of here that, as I said, in Scandinavia, everyone goes onto a waiting list for a total knee replacement. They gave people this program, the GLAD program, and by the end of the year, only 75% of those on that program avoided a knee replacement. 75%, because they did these strengthening exercises. And initially, it's twice a week. It's initially supervised, and then it's progressed. And this is what we're hoping to get funded in the new with the government around. This will be a nice thing to fund for physiotherapists, sport and exercise physiotherapists. So it helps with balance. It happens with stretching, and a lot of other clinics offer supervised group strengthening exercises, where that's sort of like clinical Pilates or gym programs. So anything with a strength program that you're doing 2 to 3 times a week with an emphasis on your lower legs will certainly help. Now, the other thing is, how do you know you're safe to move? Some people don't want to move because they feel like, I'm going to do some more damage. And there's some great resources out there from the Pain Revolution that you can look at. And these you can go onto a number of this is a YouTube video called Tame the Beast, and it's particularly those with persistent pain. And I encourage you to look at these if you're really struggling. And there's also better pain management. Sometimes we need to engage pain physicians, or it's for specific pain management. But I think that we've got to take away the evidence that any pain is bad. Some pain when you're actually doing exercise is actually okay. It's your body adjusting to load. It's not a do not do. It's a perhaps do with some caution. And under the care of whether it's a physiotherapist or your exercise physiologist or your GP or your doctor, but it's not a do not do, and it's not a always take medication for it. So braces, they were looked at by the RACGP guidelines. They feel that the lateral deloading braces are probably better than the medial, so the inside ones. These can be expensive. They can certainly help, particularly if you're not wanting to go for surgery or if you're going on a long walk or a holiday, and also manual workers. And sometimes orthotics can also help depending on the alignment of your legs. So that's something to talk about, I guess, with orthotists or a podiatrist or even your physiotherapist. So they're the lifestyle issues, I guess. And now we're going to get into the pharmacological issues. So everyone should get lifestyle, all those lifestyle interventions. The pharmacological stuff we'll talk about is supplements. Now, glucosamine is the best study. It's interesting, the RACGP don't recommend that you have glucosamine. Some people do respond to this, and if people do want to do it, I say have it for 3 months, 1,500 milligrams of glucosamine sulfate, and then stop it. And if your pain returns, perhaps it's worth continuing it, because there's no point paying for something that's not really helping. The omega-3 fatty acids didn't come up good in the guidelines, but what did was curcumin. So there's a conditional neutral recommendation, which perhaps said that you might try that. Panadol and anti-inflammatories. You'll probably be shocked to know that Panadol actually doesn't do much at all. A 0 to 4% chance of being effective. And they've looked at a whole bunch of trials comparing it to placebo. It's not worth taking it. And it's the same for the low back pain, by the way. But anti-inflammatories, they're likely to help, but you've got to watch out if you've got cardiac, so heart issues, or you've got gastrointestinal issues like heartburn. And we always say to have the lowest dose for the shortest possible time. So it might be for no more than a week. As far as opioids, again, they've been taken off the shelf here in Australia, and they're only by script. And the guidelines, again, strongly against these, because there's a high risk of dependence and more chronic pain issues. So they certainly don't help opioids. So it's nice to see that they're not recommended at all. Antidepressants. I talked about before about managing pain. The most important thing with mental health issues is that if you do need them, is to see a psychologist or even up to a psychiatrist for cognitive behavioural therapy. It should be the first line intervention for mental health issues, together with an exercise program. And again, this comes with a green light from the RACGP. And GPs can give you a mental health care plan to help with this, so that you get, I think it's 5 or 6 visits that are funded by Medicare, that are subsidised. They're not complete. So with these care plans, it's not completely covering the cost. It's only subsidising part of the cost. So it's not a free consultation either with the physio or the psychiatrist. But what they have found is one of the medications, duloxetine or Cymbalta, may also help if you are not responding to cognitive behavioural therapy. But again, watch out for side effects for that. Now we're getting into injections. This is all very controversial. Cortisone injections, they were considered a first-line treatment 2013, 2019, but a study in 2017 found that repeat injections of this, that's monthly every 6 months, is not good for cartilage, and there's certainly no reduction in pain. And there's also a recent paper out that say that it continues to not be good for cartilage. So you would only really use this for a flare-up and rapid pain relief, but it's only very short term. It's only very short relief. It's not a long-standing relief. And it was to the point that the government got rid of the rebate for this, which is about $20 back in 2006. But there's a consideration of bringing this back in 2020 with the review. Private insurance does not cover this. So be careful about a cortisone injection. And I pretty much stick to that. If I'm going to do one, I'm going to do one. It's only just one injection. Repeat ones are not good. The next is doing things like hyaluronic acid, so Synvisc or Durolane. The evidence is inconclusive to this. It's not rebated. Private insurance may cover it, and in the knee, there's a conditional against from the GPs, and in the hip, strongly against. For PRP, this is sort of taking your blood, spinning it down, taking out the red cells and the white cells, and then we can inject this into the knee. Now, there's some level 1 evidence that says that it might have an anti-inflammatory effect, but the guidelines, the GP guidelines, saying they're not sure what to do with this, but there is a big, and it's certainly not funded, and there's a big trial going on at the moment which is looking at this compared with normal saline. Because we're not sure if it's better than normal saline. So they're looking at 3 injections done and then looking at how you respond to this over 12 months. So that's 3 injections of normal saline and 3 injections of PRP. So watch this space because this will be out probably next year. Pentosan, again, is probably not, it's an experimental drug used in veterinary medicine. It's not funded by the MBS or private health, and it certainly wasn't considered for the RACGP. And this is still a research or clinical trial drug, so certainly don't go do that unless you're in a clinical trial. And I guess the last one is mesenchymal stem cells. Our college has a position statement, so that's the Australasian College of Sport and Exercise Physicians. And basically it says there's not enough evidence to support the use of this in the routine management of osteoarthritis or musculoskeletal injuries. But we do encourage that that if you're going to do it, have it as part of a proper stem cell research. And the Therapeutic Goods Association of Australia have actually made sure that if you're going to do it, you do it within very, very strict guidelines. So that's only been tightened up in the last year, because there's not enough safety and I guess does this work data out there just at the minute. We're not sure. So it's unethical and unprofessional to market stem cell interventions directly to patients. But we hope that, as you can see, there's people live longer. If surgery is not going to help, there's got to be something that's actually got to be able to help people to actually help with their knees. And I don't think this is actually going to fix the structures in the knees because, as you say, people can be pain-free with abnormalities on their MRI scan. So this is on the Musculoskeletal website, 5 things you should know about stem cells, and I encourage you all to look at this before you even consider this. And the GPs actually don't recommend it at all. So I've gone through this: lifestyle, pharmacological and surgery. And I'd like to think that these circles reduce down to this over time as lifestyle becomes the biggest way that we can actually manage osteoarthritis. And prevention is important, where there's a lot of work going into preventing this, particularly in children and when we're younger, as far as in football, netball, soccer. There's a lot of these programs can reduce the incidence of certainly ACL injuries by anywhere between 50 to 80%. So we've got to put a lot more money into this. And this is part of the National Osteoarthritis Strategy, which we hope to see funded. At the moment, the government's only committed $4 million to this, which is not a lot considering how many people in Australia have this. So there's a lot of work to be done. And I think the biggest thing we can do here is try and stop obesity. And this is my final message for you. Osteoarthritis, I guess, is really common. You may never need an MRI or surgery, but it's safe to get moving, get strong, and losing weight will also help you. So I thank you for your time, and I hope there's some questions that I can answer. And I hope that's given you a comprehensive way of how you can manage your needs. So thank you.
Adam, thanks very much. That's an incredibly detailed presentation with lots of information in it. So I really appreciate the work that you put into that. And I'll just remind everyone that because there's so much information in there, everyone will be receiving a recording of the webinar tonight, next week. So if you want to play that recording again, you can slow it down and stop it, just because Adam has included so much information in his presentation this evening. Also, Adam's very happy to share his slides of his presentation when we send out those resources next week. Adam, we have a couple of questions which we'll try to get through in the next few minutes. There's a question: are you using OTS?
OTS, not sure what that is.
Okay, we might seek clarification from Jennifer, who asked that question.
Yes.
Is anyone in Australia injecting Lubricin?
I'm not sure what Lubricin either is. I mean, so there's the thing that it would, I think, assuming it may be the closest to, might be the hyaluronic acid, which is like the Synvisc or the Durolane, which is almost like it's like a, as I say to people, like Castrol GTX oil. So it's like a lubricant, and it's like it's a buffer inside the knee. But I don't know of lubricant being injected in Australia, so I don't know who does that. No.
Okay, a question about exercise that can be done at home. You did sort of say, look, weight bearing. If people can in a way be a bit inventive, I guess, with some of the things you were suggesting.
So that's a good question, and a lot of patients I have say, and I give them, there's 4 exercises that people should do. One of them is actually being able to get up off a chair, so it's called the sit to stand, which is like a squat, so getting up off a chair, trying to do 3 sets of 10 of those 3 times a week. The other one is trying to step up onto a step, so you do a step up onto a step, and that might be 3 sets of 10 of those 3 times a day. The other one I do is get people to do double leg bridges. So they might be lying on their back and trying to lift up their pelvis they bend their knees and try and lift up their hips off the bed. So again, 3 sets of 10 of those. And then the other one might be getting an elastic band and wrapping it around your legs and you just bend your legs a little bit and do a side walk, so like a crab walk, because that's good for strengthening your glutes and also for your quads. So they're the 4 that I would really be doing for people at home. And you can do those at home. All you need is an elastic band and maybe a stair. That's it, and a chair. So they're the things you can do in the park as well. So they're the ones I give people for their legs.
Okay, someone else has osteoarthritis and severe psoriatic arthritis. They're using a pain management technique of starting with a very small distance and increasing very slowly. They've now reached 4 kilometres 4 times a week, which is great. But I'm just wondering whether they should be doing 30 minutes each day instead. They're also doing yoga and weight-bearing exercises.
So my advice is if you can keep up your 30 minutes of walking each day, that's a great thing. But sometimes you might need to just lower the loads with that. You could get to a pool once or twice a week is quite good to do just walking up and down the pool, because there's a bit more resistance there, but it's also, you're not as heavy, you're actually held up by the water. So I think getting to a pool is one of the best things that you can do to actually help with movement. And it's not, you're still a bit buoyant, but also yoga and the weight-bearing exercises are fantastic. But as I say, if you can get in to do your 30 minutes a day, that's where you have the maximal effect. You can, as I say, you can add 7 years to your life. So that's the minimum that we want people to do. As I say, anything that helps, though.
And someone who's a health professional says that they see a considerable number of elderly clients with genu-valgum deformities.
Yes.
How do you think they should be managed? That this person works on strengthening their quads and sit-to-stand function, but they are still weight-bearing through a mechanically altered joint, which results in pain.
Yeah, so we do see a lot of that. Which genu-valgum means that the knees actually come in. So a lot of that is not just quads, because if you strengthen the glutes, it actually stops the knees from moving in. It moves them out. So they've said there the hip strength. As I said, sometimes you can have an orthotic in the shoe, so you might have a medial wedge orthotic in the knee. That can sometimes help as well. And also you can have maybe a brace might also help that. So they're the sort of things that you can try, an orthotic and maybe a brace for the knee to help with that. Anything else for pain might be just, as I say, keeping the weight loss certainly helps, and maybe a bit of anti-inflammatories.
There was a question about plasma injections, but I believe you covered that in
yes, I did.
In one of your latest slides.
Yeah, and the other thing about the genu-valgum deformity is sometimes they do talk about surgery to realign that, and if you've got sort of pretty advanced arthritis, the realignment is not going to help significantly, and that's another big operation that it certainly can help in some instances, and that's sometimes you might go and see an orthopaedic surgeon for an opinion on that, but it's again, you want to make sure that you've done everything else, which it looks like they're doing there, so keeping up the strength.
Okay, and I think that's last question is, it seems all pretty straightforward: education, exercise, weight loss. What do you think the challenges are in delivering this care to people with OA?
So I think the biggest challenge at the moment is the affordability of getting this information from, first of all, is GPs need to be aware of these guidelines and help to implement them and give the appropriate referrals. But I think the referrals to physiotherapists, whether it's sport and exercise physiotherapists or physiotherapists, exercise physiologists, is people sometimes can't afford to see them more than once. Some people might need the classes that might go a bit more. So it's often getting engaged in, say, clinical Pilates class once a week or twice a week. And that can be expensive over a year. And as I said, if you're going to pick between $320 to do an MRI scan or $320 to do Pilates or a gym program, you would go for the strength program, the exercise program every time. Absolutely. Absolutely, because that's going to help what you need to do. And if you do need an MRI scan that's rebatable, I would be trying to get in to see a sport and exercise physician or a rheumatologist or an orthopaedic surgeon, because if you get an MRI through a specialist, regardless of your age, it can be bulk billed and you don't have to pay for it.
Great.
So, yeah.
All right. Listen, Adam, look, thank you once again. We're right on 8 p.m, so we're going to finish there. Thank you sincerely for a fantastic presentation tonight. Thanks again to Peninsula Hot Springs for sponsoring tonight's webinar. Before you close off, everyone, can I remind you to stay online, as our exit survey will be coming up, and we very much appreciate your feedback. So thanks, everyone. Please go to the Musculoskeletal Australia website. This recording will be there, and you'll also be sent the resources next week. So thanks, everyone, and I wish you all a good night.
And thank you.